Thank you very much indeed. So I hope my finger is slightly more sensitive than John's. Okay, for those of you that came to the talk I gave earlier this morning, there's a few slides I've used again, so apologies if you were at that talk, but view it as revision. But I think actually that talk I gave feeds into this talk, and actually it feeds on very nicely from what John was saying. So I'm going to touch on epidemiology and then go to pathophysiology. So we get these gory statistics, you know, sepsis kills 44,000 people every year in the UK. Every 3.5 seconds someone dies from sepsis. And so there I am in the front. And the bodies are just piling up every 3.5 seconds. Oh, another one. 1, 2, 3.5. Oh, another one. Is this reality? So let me put the numbers in context. So English GPs in 2015-16. So we're about, in England, about 3/4 of the United Kingdom. So I'll give you NHS England figures. 34 million antibiotic prescriptions, and this is a population of about 55 million. Wow. Okay, some patients may have got more than one, some patients may have got the antibiotic for acne, but that's a hell of a lot of antibiotics. In terms of patients being discharged from hospital, alive or dead, with a code of sepsis or infection, 1.3 million hospital patient episodes. And there were 32,000 in hospital deaths. So if you do the maths, that's a mortality rate of 2.5%. So most people who come in who are treated for infection or sepsis, either coming into hospital with it, developing it in hospital, actually survive. And of those 32,000 deaths, only about a third actually go through the intensive care unit as part of their sort of dying pathway. So does that mean we're very bad at, patients are dying on the wards, waiting for an ICU bed, die in the operating theatre, the emergency department, or perhaps we can ask another question. Do they die of or with sepsis? So how many of these patients who do die actually warrant an ICU admission, warrant life-prolonging therapy? And the guy there in the middle is Sir William Osler, and he used to say pneumonia is the old man's friend, and perhaps in 2018 we can call it sepsis is the old man's friend. And I think it's fair to say that patients may be allowed to die either from or with sepsis due to the severity of their underlying comorbidity, be it terminal cancer, renal failure, heart disease, respiratory disease, dementia, whatever. Often it's the last sort of nail in their coffin, and it may be an appropriate nail. Again, going back to NHS England data, this is looking at age. This is over a 6-year period. So lots of very small children get admitted, probably a lot of parental anxiety, especially these are below 6 months old in particular. But as you can see, it goes up and up and up with age. The mortality figures actually look quite different. Thankfully, very few people at the left end of life, the youth, actually die, which is actually obviously nice. But you can see it goes up and up and up, taking off in middle, late age and beyond. So more than 3/4 of those dying in England with a code of infection or sepsis are at 75 years or above. Only 8% are below retirement age. So again, we're looking predominantly at those who die as a disease of the elderly who probably have multiple comorbidities. This is from Chris Seymour's paper in the New England Journal, the New York Mandate paper. I'll touch on that later on. And they looked at 49,000 patients admitted to hospitals in New York State, where they were mandated to get this sort of early bundle. And look, the interquartile range. So 1/4 of the patients were 83 or above. Lots had chronic respiratory failure, heart failure, end-stage renal disease. They don't mention in the paper how many had dementia, stroke, cancer, other severe disability, and a quarter came to hospital from a nursing home. So many of these patients arguably were at the latter end of their meaningful life. Is death from sepsis predictable? How many of these patients we get are truly salvageable? So if you look at the literature, there's loads and loads of biomarkers that, taken on the first day of intensive care, show a poor prognosis. So we've got cortisol prognostic, catecholamines are prognostic, lipid profiles, cytokine profiles, inflammation, coagulation, fibrinolysis predict mortality, estradiol, low levels of cholesterol, thyroid function and mortality, high troponin, BNP, autonomic dysfunction predicts mortality, microRNAs in the blood, plasma DNA in the blood, nucleated red blood cells in the blood predict mortality, soluble L-selectin, metabolomic derangements, mitochondria, have to get in there, and my favourite one from Japan, fecal pH. You didn't know that, did you? So there's a U-shaped curve and there's a sweet spot that you want your fecal pH to be at. Interesting. And these are in intensive care. You can even take it back to when they present in the emergency department. This is a nice study from Holland, the Netherlands, where they looked at patients with suspected infection, and the troponin level on arrival was pretty good at prognosticating. So you had an area under the curve of 0.8. Also, this is from the Jennings study. These are patients presenting to emergency departments in the United States with pneumonia, sepsis, and again, it was looking at sort of, polymorphisms, etc., which it didn't show. But a really interesting paper that came out of this was the cytokine profile on admission in the emergency department was prognostic. So the severity didn't match, and as John showed earlier, there was this huge range of cytokine levels, but you can see those with a low level of interleukin-6 and interleukin-10, a sort of pro and an anti-inflammatory cytokine, you had about a 5% chance of dying at 90 days. On the other hand, if you had high levels, you had about, you had about a 50% chance of dying. In the emergency department, these patients could be differentiated. Likewise, this paper from Ray Langley, this was one of the early papers looking at metabolomics, transcriptomics, etc., proteomics, very nice little paper. They took blood in the emergency department and then again 24 hours later. And what did they find? Again, there was a marked difference in the metabolome and the proteome between those patients who would go on to live and those patients who would go on to die. And they looked at different things and they grouped them into, obviously, some metabolomics, so fatty acid transport, beta oxidation, Krebs cycle, and so forth. And they differed consistently among several sets of patients, and the bloods taken the following day, there was an even greater divergence. And interestingly, those who were getting sicker, who went on to die, it was carrying on diverging, whereas in the survivors, the pattern was similar, regardless of severity. So the question is, the patient comes in and you've got a pretty good go at guessing, you're going to die and you're going to live. Therefore, what we're currently doing, you could argue, is perhaps supporting the patients who are going to live, but just prolonging the death in those that are going to die. And I think that's one of the triumphs of modern critical care, is we can prolong death very effectively. But clearly it's not good for us, it's not good for the country, it's not good for the patient or their family. So what can we do about it? I talked about this morning, I'd like to revisit it. So this guy's Robert Hooke, and for those of you who have a dim, distant memory of physics, he did Hooke's law. He was a physicist. And so he took springs and basically showed when you put a force on that spring that it causes deformation, a strain, which were initially proportional. And so you can see this diagram here. Initially, Hooke's law is obeyed, and then when you pull that spring even more, it begins to yield, and then eventually it gets to a point where the spring doesn't return to its original shape. It's permanently deformed, and you keep pulling, and eventually it fractures. That was unscripted. Okay, that's material physics. Why don't we translate that to the body? Why not deformation of the body and force being a biological stressor, be it infection or trauma or whatever? So we have strain on the organs versus the force. So we have the acute illness, and by and large, we're pretty good at fighting acute illness. We get better. Only a relative minority yield and develop organ dysfunction. And then, clearly, the patient will either carry on deteriorating and die. On the other hand, hopefully, some of them will recover. So maybe there's this point of no return, that once they get to permanent deformation, we can't pull them back. Maybe. And patients differ. You know, clearly, as you get older, as you've got comorbidities, perhaps your resilience to an insult gets less and less and less. So we've got a patient who perhaps is less resilient, and so that curve may be shifted to the left. So potentially, the organ dysfunction will happen earlier in these patients, and maybe that point of no return may be shifted to the left. On the other hand, the more hardy, resilient souls, and it can apply to old people as well as younger people, again, maybe, in my experience, we get lots of alcoholics. They're really resilient. Maybe developing the organ failure, maybe that point of no return has shifted to the right. So in the stress literature, 3 phases are described by multiple people in different ways. But maybe phase 1 correlates with the acute illness, phase 2 with the organ dysfunction, phase 3, which can go to a recovery mode or a death mode, follows on. So maybe, let's go back one. So maybe phase 1, we should manage the patient in a different way. There, the patient is trying to fight the infection or whatever, and that's where we need to support physiology, the derangement. So that's where the resuscitation comes in. We don't want to underdo it, we don't want to overdo it. And maybe that's when we can target immune or other pathways, so we don't want the exaggerated response, especially in the less resilient patient. When we get to phase 2, they're in organ dysfunction. Is there any point? The organs have shut down, they're not working. Is there any point trying to flog them with all the things we do to them? Or perhaps we should leave them alone until those organs show signs of recovery. So during phase 2, perhaps we need to support the cell's own attempts not to kill itself. We need to, protection, the tolerance mechanisms, which I won't talk about now. And in phase 3, when the patient's recovering, we need to support that recovery. We need to slowly move towards getting the patient back to healthy physiological values, nutrition, etc., rehabilitation, all of these things to support the recovery. And maybe when the patient's going in the other direction, perhaps we should prepare them, their families, for death, or wouldn't it be nice, in the appropriate patients, to discover if there is a reverse button. So instead of these patients we predict will die in the emergency department or on day 1 of intensive care, and now 2, 3, 4 weeks later, we're thinking they're not getting any better, it's time to stop. Wouldn't it be nice if we could reverse that course? Again, if you look at what we're doing conventionally, are we actually having a big impact? So I refer again to Chris Seymour's paper, and they found the early antibiotics given within 3 hours makes a big difference. Well, does it make a big difference? If you read the paper, 2/3 of the patients who didn't get vasopressors, there was no impact from antibiotics. And there was an odds ratio of about 1.05 in those who did get vasopressors. But that's not a risk of dying that goes up by 5% an hour. it's the overall risk, it's the risk of dying. So if you look here at the absolute numbers, if you got that bundle within 3 hours, there's only 1% absolute difference. So the mortality risk, it's 5% in the shock patients who got vasopressors, 5% of the risk of dying, which is actually quite small numbers. So again, what we're conventionally currently doing isn't, I would argue, making a huge impact on outcomes. We need to move in a different direction. John touched earlier on the sort of phenotyping. Again, lots of other questions on the paper. We don't know why, if treatment was mandated. Was there a delay? Was it some patients? There were lots of discussions about how aggressive we should intervene. We don't know. So targeted therapy, as John alluded to, I think is the way forward. So we need to better define sepsis. I like using this paper. Marcin Ossakowski, who is here at the Congress, did this very nice paper a number of years ago, where he gave steroids to his septic mice. And you can see it didn't work. Oh dear, steroids don't work. However, before he gave the first dose 8 hours after the insult, he'd shown previously that you could predict the outcome on the interleukin-6 level taken at 6 hours, 2 hours before the steroids were given. And here, I'll go down, here you did see a difference. So in those who were predicted to die, there was a significant benefit from the steroids. There was a trend towards harm in those predicted to live. Is that translatable to patients? We don't know. But at the moment, there's no change or maybe a slight benefit from giving steroids, but perhaps we're benefiting some and offset that with harm to others. The same with beta blockers. So Andrea Morelli, a nice single-centered trial. Again, it's been criticized for the high mortality rate, but he picked very sick patients. And giving beta blockers to these patients, obviously it has effects on the heart and loads and loads of other effects, there was a reduction in mortality rate. I'm going to have just this one slide, avoid iatrogenicity, because I think, again, a lot of the things we do may contribute to harm. So perhaps, and I think that's what we've learned in intensive care, some of the incremental benefits we've seen in the last 10, 20 years have been down to doing less to the patient. So clearly there'll come a point where there's no further iatrogenic harm, and then we've got to look to do something to reverse nature. So in conclusion, I think most septic patients who end up dying are elderly and or have significant comorbidities. The clinical biological phenotype on presentation are actually good predictors of subsequent outcome. We're very good at keeping the expected survivors alive, and we're very good at delaying death in those who can be predicted early on to die. And so I think new targeted treatment paradigms, I think, is the next major step forward that will truly make a difference. Thank you for listening. Thank you.